Thank you, Mr. Prasanna, and all the rare disease community for making this possible during these times. It's great to be here with all of you. Thank you for the opportunity. I'd start off with this thing because I think this is, Mr. Prasanna, this is a great idea with regards to what happens to rare diseases. At the moment, for the last 3.5 months, Corona seems to have taken over our lives. And I don't think there's anybody in this room who is in this virtual room who has not been affected by COVID-19. So I'm talking with regards to what happens, how it's affecting our rare disease community, our small rare disease community, those children and families with Duchenne muscular dystrophies, SMAs, and other neuromuscular disorders. And we also talk about what the standards of care are and how do we manage or maintain standards of care during these difficult times. And the backbone for SOC is MDT, multidisciplinary team care. How do we take care of MDT during COVID-19? So these are some of the things I'm hoping I won't be the only one talking. I'm hoping we can have some sort of dialogue with the families as well during this. So the current crisis has unmasked all over the world global unpreparedness. So these are not new problems. These are existing breaks in our system which have just been unmasked and have just come to light because of Corona, the pandemic. But there is a silver lining to this cloud. The silver lining is that there are opportunities in this crisis. We will come to this. I'm not saying we should want the crisis, but we shouldn't. I think it's one of the statesmen, one famous statesman who said that you should never let a good crisis go to waste. So there are opportunities to be taken from here. So for the vast majority of people, as parents taking care of children with rare diseases, most of you who are here today are people who are highly motivated. You are highly motivated, so you know what is necessary, so you have health-seeking behavior. So then what happens is that you have certain goals. You can't reach those goals because you can't meet specialists or certain specific hospitals, and then you start getting very panicky or anxious. And then you also start not being able to put the whole picture together and not taking the corona as seriously sometimes. Because sometimes nobody you know has died of corona. So it becomes an abstract threat. Let me share here with you, three colleagues of mine in the UK and the US have died of corona, people my age. So this is not an abstract threat. So this is very much a real threat. But many times because we don't know people, we think it's a threat. And so we may take it too lightly and we may end up by it coming too close to home. So this is an interesting article that I found on the internet. This is not a scientific article, but this was from the European Consortium in 2019, in October, just before Corona hit. Multiple stakeholders were asked to contribute, and they were asked to say, what do you think are wildcards? What could happen which could be obstacles to the care for rare diseases in the next 10 years till 2020? So this was a EU-funded project. And what they found, interestingly enough, many people, as you can see these big blobs, the bigger circles represent more number of people pointing them out as a potential crisis. So some people said economic crisis, some people said wars, some people said epidemic illness. And this is where we are today. This is where we are. And this is totally disrupted. Immediately what happens is this total disruption immediately. And then you have the next stage, the second half. The second half of this diagram is reaction to it. Public rejection or discrimination, immigration and everything getting affected, less solidarity, and all this kind of stuff. And lowered funds, collapsing of existing frameworks and government infrastructure. So we are having to postpone all elective care. Also, there is an acute shortage of trained healthcare and professionals because it's affecting our health as well. And there's also shortage of equipment. Every single equipment that you use takes the amount of time it takes to see, for example, to do an echo, it takes double the amount to see from one patient to another because the whole equipment has to be sterilized. So there's less number of patients that can be done. So I'd like to take some history lessons from here, something that we could learn on a positive note from the flu pandemic of 1918. 50 million lives, nearly 2.5% of the global population at that time in 1918, between 1918 to 1919, there were three waves of it, three peaks, so to speak. So 50 million lives were claimed. Prior to that, the worst was in the 14th century. Black Death in the 14th century. Then both COVID-19 and flu, the flu pandemic, the Spanish flu, both are viral in nature. They're different, but then they have some things in common and some lessons that we can learn. Both are respiratory spread and both are called crowd diseases. So in some ways, in a weird way, World War One came to an end because of flu in many ways because the casualties were too high. An estimated 18 million Indians died in 1918 because we had contributed our personnel to the First World War, and we had the highest death toll of any country. And again, it was because of that. So the same history repeats the same problems again and again. Those who are underprivileged, those who are malnourished, those who are crowded, have less socioeconomic strata, people from those kind of underprivileged circumstances, they're the ones who die. So that's what happened in 1918. So, but then the result was that from there emerged socialized medicine, where people came out together saying that it's not right for medicine to be privatized or only available to certain individuals. But this is not something that one individual can decide. This is something that, as a society, all of us have to come and change. The push for socialized medicine happened in Europe. It became in a different way in the US. We still haven't reached there yet. We still have a hodgepodge system of medical health care. We still have some insurance, some people paying from their pockets, mostly paying from their pockets, some government based care, but it's not uniform. So maybe this will push us towards more solidarity. So, some of the four factors that are going to change, hopefully, this is our turning point in history, and everybody's going to say pre COVID and post COVID. So, the geopolitical landscape, we already are facing war with our neighbors. The geopolitical landscape, our relationship with our neighboring countries is going to change, not just for India, but for the whole world. The one good thing is that it is forcing people to collaborate more for scientific research. We know for a fact that for many of our children with SMA and DMD and many other genetic diseases, it is so easy to come up with cures, but because of patency, because of pharma and vested interests and other things, it is becoming very difficult. There are lots of obstacles to jump over, hurdles to cross before we get there. But hopefully, COVID has proven, and will at the end of COVID will prove to all of us that it is possible for everybody to overcome these interests and to collaborate. And maybe we can take away lessons from there. Maybe we can benefit. And artificial intelligence, its contribution to this. So the way we come together, like what we are doing right now, information, communication, and technology, we are all meeting together, irrespective of which place in India that we are in, we are communicating with each other today. Telemedicine, that has become legal in India as well and in many other places. So this may be our new reality. So throughout history, an important thing to notice is that pandemics have been turning points in getting more people together for more solidarity. So coming to DMD. So DMD, as many of you know, is the commonest muscular dystrophy affecting young boys. Affecting boys, it doesn't usually affect girls, and it causes proximal weakness, weakness in the upper limbs, closer to the shoulders and closer to the hip girdle, and gradually progressing weakness, which causes breathing difficulties. And 100% all of these children have heart disease involvement. Some early on, before the 10th year of life, and almost all of them by 18 years, by 20 years, everybody's involved, heart is involved. They also have additional health burdens, such as bone health involvement. They have increased fractures, their bones are thicker, and they also have bent spines, like most neuromuscular disorders. So there is some children also have a problem with the way they think, and this happens in specific type of mutations, and they have something that is similar to autism, not exactly autism, but something that is similar to. And their IQs are usually on the lower side. But we have many children with DMD who are very, very clever. So this is just some basics. So our dystrophin gene. So this is our muscle. Multiple fibers are there, and you have this is at the cellular level, and this is your dystrophin protein. So this is what happens, the dystrophin protein. This acts as a shock absorber for the muscle. When the muscle contracts, the muscle doesn't break because the dystrophin, this protein acts as a shock absorber. So this is connected. There are multiple other proteins. These proteins are also involved, we'll come back to this later, in the various other muscular dystrophies and muscle diseases. So this is a shock absorber of a giant plate truck. And if we don't have shock absorber, the truck will break and it cannot sustain itself on journeys. So this is a cartoon of the gene of dystrophin gene that is responsible. The body reads through this gene like a recipe and produces this dystrophin protein. This is the dystrophin protein, which acts as a shock absorber. So this is the dystrophin gene. So you need, this is, as you can see, it's like a jigsaw puzzle. Each puzzle is different way. So what happens if you have one piece of the puzzle missing? Here 11 cannot fit into 13. This is just an example. So 11 and 13 don't fit into each other. So it cannot read through. So no protein is produced. Zero protein is produced. So you have nothing produced. And so this is the commonest kind of mutation or change in the genetic material that you see in muscular dystrophy. So that constitutes nearly 72%. They are large deletions or large pieces of missing chunk. About 7%, a bigger chunk. The next bigger volume is pieces that are doubly present. Even if you say, for example, here you have 12, you have doubly present, it's still, the jigsaw will not fit. Then there are other types of mutations which are called point mutations, which can be missense or nonsense mutations. So these are important in making cures or finding out cures for children with Duchenne muscular dystrophy. But while that is the job of scientists, us as stakeholders, you as parents, Mr. Prasanna and ORDI as advocates for children with rare diseases, and me as a doctor and other people who take care of children, I'm not a scientist and we can't find out the cure for this. We can raise our voice for it, but what we can do is use existing data and do the best we can for our children. So natural history of Duchenne muscular dystrophy without any treatment is that they don't survive beyond the second decade. They don't survive before their 18th birthday, usually 14 to 18 years. That's the fact. But if you give them without a cure, if you give them supportive care, the oldest patient lives in 52 years in France. So usually they live till their 40s, even without a cure. A cure is well within our reach. Till that time, people have come up with these standards of care. We take care of the weakness. We make sure that we know this is a naturally progressive weakness, disease that causes weakness. So we start them on steroids with adequate precautions. So we take care of the bone health. We take care of their height and other things, their obesity. They can put on weight. We take care of their heart, very, very, very important, their breathing. And some children who have communication disorders and autism-like illness, we take care of that. And we take care of their gastrointestinal system because they're not walking. They may have constipation. And occasionally later they can have constipation and swallowing difficulties. So also when we start steroids, which is the mainstay of treatment, there are side effects of steroids, which becomes the responsibility of both the treating doctor as well as the family. It's a commitment from both sides to ensure that that doesn't happen. So there are various regimens. I'm not going into the nitty-gritty of all of this. There are side effects to be done, but the side effects can be taken care of. So a simple example is a side effect like cataract. It's very, very rare, but cataract is not life-threatening, whereas DMD is life-threatening. So same with most side effects. We can anticipate and prevent them. So these are just a wide outline. They're freely available on the internet. These are the current guidelines from 2018. And this is from the 2010 guideline, which is the importance of what it means. It's not one person's responsibility to take care of, or it's not possible for one individual to take care of a child with rare disease. You need multiple people. So this is very important for all of us to remember. So if this seems like a very difficult and tall task, but I would like to bring your attention, just remind ourselves of this. I think most of us know who Stephen Hawking is. This is a quote from Stephen Hawking. Oopsie. Saying that, and however difficult life may seem, there is something you can do and you can succeed at. It matters that you don't just give up. I think this is something that our rare disease parents always know, that you don't give up. Otherwise, you wouldn't be here. So as a medical fraternity, we are trained to fix things and treat things. cure versus treat is always difficult. So at the moment, till we get a cure, it is standards of care and multidisciplinary team that we need to do. So in the current scenario, where you may find that there are maybe 2 or 3 centers in the country which do multidisciplinary care and complex management of children with Duchenne muscular dystrophy and SMA and other rare diseases, where you can't cross state boundaries to come to us, then you would have, then this is also a good opportunity for us to engage in local people, because you can't always rely on your specialists, and specialists have a lot of patients as well. So this is a good opportunity to network, get one patient. So for example, we in our center have over 100 children with Duchenne muscular dystrophy, nearly 200 children with SMA. So for us to take care of each of those individuals, each time when we see children with those, it takes nearly 2 hours or more to see each child. So in a day, we can see only limited number of children. And every day we are seeing these children. Instead, if you have a local doctor, it doesn't need to be somebody very specialized. All you need is somebody who's sympathetic, a local pediatrician or a local general physician who's willing to listen. You get hold of that person and put them in touch with us, rather than families contacting doctors, because you don't speak medical language. It is difficult for us to communicate with them. Then we form a network, and then together we can be stronger. Then we can even do telemedicine. If so, as a doctor, I cannot examine a patient, especially a neuromuscular patient, over the video. So some certain conditions we can do telemedicine, but neuromuscular becomes difficult. Whereas I can ask that doctor to do it, then it becomes that much more easier. And that doctor becomes your stakeholder. That doctor is going to fight for you. And that doctor who's locally present for you is your first port of call. And then for that doctor, you will be a special patient, because you will be the only person with DMD or SMA who's there with that doctor. But you would, as a parent community, you would have to also bear with them that they have not seen another child with a rare disease. But all it needs is that they're interested and willing to give their time. So some societal challenges are perception of disability. So for example, if I were in a Muslim community, country, or in the Middle East, being a woman might be a disability for me. I am short-sighted, that might be a disability, according to some people. So this is all perception. You are as able as you think you are. Just because you're in a wheelchair doesn't mean you can't do things. So impairment is loss of function, and handicap is loss of identity. Loss of function, maybe we can't always prevent, but loss of identity we can always do, I think. As a community, we can do that. So the answer to this challenge is always enable. We enable people and come together and do this. And you don't need to be a doctor or a nurse or anybody to do that. We can all do it in our own place. So this is just to give some hope. This is as of today. Every time I like doing this, every time I do this talk for DMD, I keep doing this on clinicaltrials.gov. This is a freely available resource maintained by the US National Library of Medicine. So these are the current studies for Duchenne muscular dystrophy, and it keeps changing. It keeps increasing, the number of studies. And currently, the studies that are active are 118. So this is very important. And when you look at it, there's so many new therapies, Vamorolone. There are multiple intervention strategies. Dystrophin, as we know, the lack of dystrophin is what causes Duchenne muscular dystrophy. So, and it's downstream secondary effects. So lack of dystrophy, no shock absorber, muscles die, but also there is inflammation, fibrosis. So that is where we give the steroids. And there are a lot of other steroid analogs, medicines that work like steroids but don't have the side effect steroids, like Vamorolone, and lots of other things. But then gene replacement therapy is another one, and so there are a lot of other. And there's also what we said. We saw the the cartoon of the gene of the dystrophin gene, and how if there is a deletion, how to read through it. If there is a stop codon, how to read through it. This too, in trial. This is already there, ongoing. And then the exon skipping. This is what we talked about. When this piece is missing, you skip it. You skip another one, and then you join 48 to 52. That's a 51 skipping. So this is the 51 skipping. This is already there as I got this. Epilepsy, and this is also there for 45 and 53 skipping now. So this is applicable 14% of DMD children. So CRISPR-Cas is another way of treating. Utrophin upregulation is another way of treating. So these are just to keep up hope, that hope is on the way. Things will happen. And so stem cells, as of now, it is not yet available. So what is available in India is not really allocated. Your Indian government ICMR website says it very clearly that it is not legal to give it to Duchenne muscular dystrophy and other muscular dystrophies. except for certain other conditions like blood cancer. So this is just to highlight that the cardiac aspect. This is something that this is very close to my heart. Um, Cardiac involvement in children with Duchenne muscular dystrophy. Because these children do not walk, early involvement of heart muscle is not seen. There's a stress and strain on their heart is not seen. They don't get heart attacks. Or they do get, but nobody notices it because they don't get pain, because they're not walking. So they can have rhythm abnormalities. The way their heart beats, there can be an abnormality. So it's very important that they have a special echo, not a normal echo, with fraction shortening, and ECG, as well as a 24-hour continuous monitoring. This is something that we have seen in our center over the last year and a half. We've noticed that we are picking up early changes in children as young as 4.5 and 5 years of age. This would change their life and they would live longer until at least a cure is available. So, at 10 years of age, it's currently accepted practice that anybody, whether they have recognized the heart disease or not, gets medication to prevent heart disease. So, early scoliosis care. So, steroids is the backstay, and they do have side effects, but we manage the side effects. And so the future for DMD and many other neuromuscular disorders is that it is going to be personalized medicine. It is going to be individually tailor-made for each child. And hopefully this will be available for everybody soon. So SMA, another common disease, which is common in our country to our high level of interrelation marriage and consanguinity. So second most common autosomal recessive disease, meaning there's half a copy there's a spelling mistake in the father and the mother, and both coming together, the child has a problem. So the commonest is the type 2 SMA, and 1 in 6,000. These numbers are a little vague because we do not have registries in our country. What? Father is a carrier, mother is a carrier, and you have this child here who's affected. Whereas you have two other children who are not affected. So it is like playing toss with a coin, head or tails. With each pregnancy, you're playing this toss probability game where there is a 25% chance of an unaffected child, 50% chance of a child who's carrier, and 25% chance of a child being affected. So there is in SMA, the SMN protein is not produced, so that protein is necessary for a special neuron called the anterior horn cell in the spinal cord that controls your movements. So progressive loss of this causes progressive weakness and progressive paralysis. They have difficulty breathing and swallowing and poor weight gain, and the classical SMAs do not survive beyond 2 years of age. So this is what happens. Your brain controls from your brain, it goes to the spinal cord, and from the spinal cord to the muscle. So in DMD, it was a muscle that was affected. Whereas here, so in a stroke, you have the brain affected. Here it is the anterior horn cell that is affected, and from there it is going on. So in SMA, this is the gene, and here the SMN gene produces the SMN1 protein. Full protein is produced. And the SMN2 gene can produce it as well. So human beings have two proteins, SMN1 and SMN2. But what happens is that in SMA protein, SMN1 does not function at all. So this is a normal muscle that looks healthy under the microscope, but this is a diseased muscle. So you have this nice neuron, but here is this diseased, thin-looking wasted neuron. So these are the different types based on severity of when they appear. Those that appear less than 6 months are very severe. Those under 2s, those that occur before, these are different types. Those that occur before 2 weeks, before 3 months, before 3 to 6 months, 7 to 18 months, 18 to 3 years. Those that are older, in older children, more than 3 years, and those in adults. So there are milder forms that happen in adults where they walk as well. So all of them have the same mutation. So this is another area where research is studying that even though all of them have same mutation, they manifest differently. Everybody has zero copy of functional SMN1, but some of them have different copies of the SMN2 gene. So all the therapies that we are thinking about are based on these modifiers that are naturally occurring. And that's how cures came about. So if those people with higher copies of SMN2, they do better. So some of the modifiers are TLS3, NCALD, and these are the other genes. There's a lot of genetic complexity. So this is a study with more than 1,000 children. A Spanish cohort says that in different groups, there were more. So for type 1 SMA, there were so many SMN2 copy numbers in this many numbers. So it was different in different groups. So this is again coming to the SOC, the standard of care for SMA. It's just looking at SMA children, how difficult it is for them to get up. This is our own series, but this is quite a bit old. Our series is now nearly 200 children old. And we had, at that time, 66% of our patients were type 1, and 24, about a quarter of them were type 2, and 10% were type 3. So almost all the type 1s died with. And this is in comparison to the registries from North America and Europe, in New Zealand and Australia. So overall, like DMD, we need to take care of their motor ability, their breathing ability, their bone health, spine, nutrition and feeding. Neither overnutrition nor undernutrition, and importantly, psychosocial. Because our children with neuromuscular disorders are very clever, which also means that they're going to think more things. So we would need to not hide things from them, tell them reality, and also give them the courage. Actually, more often I find children are stronger than patients, than the parents, and make them part of their struggle. So these are some of the standards of care. So we take care of swallowing problems even when they aren't very obvious. We preemptively take care of respiratory illness, because once they get a chest infection and are admitted in hospital, it's already too late. Then it becomes difficult. So we take care of, there is a complex relationship in chest, because their bones are weak, their chest wall is not formed very well, their compliance is not very good, they already have scoliosis. Then they also do not have good expansion of lungs, because they don't have the ability to expand their lungs. So indirectly, there may be affectation of the heart. So the pulmonologist, the chest specialist, and the neurologist, pediatric neurologist, need to work together closely. And sometimes GRD can, the reflux that is not detected can also add to it. There is some role in antibiotics as well. Sometimes some children, we give antibiotics to prevent infections. So we also sometimes vaccinate children to make sure they don't get influenza, which is seasonal, and every year they can get it. So again, like the DMD algorithm, here is an SMA algorithm for MDT, and some of the principles: managing their contractures, their splints, TLSO. These are the splints. The thoracolumbar spinal orthosis for scoliosis. Chest physiotherapy, if they get both to prevent chest infection and also to make sure the chest infection, they tide over chest infections quickly, recover quickly. Early mobilization of fractures and injuries. This is a very important point for all our neuromuscular patients. If I'm a normal individual breaks a limb, a leg, you would be immobilized for 6 weeks. But that should not be the case for our children with neuromuscular disorders. They should be mobilized under supervised conditions sooner, because this is enough for them to lose walking ability. The nutrition again is important. Too much is also bad. Too little is also too bad, because many times they become too slim and lose a lot of weight, and so they don't have any reserve to fight infections. One single chest infection or a cold or a cough can knock them off. So it could be a sign of occult or hidden respiratory failure, which you may not know that you're hyperventilating at night, and maybe you need a sleep, nighttime ventilator. This is the consensus guideline. This is also freely available on the internet. And so these are the studies for SMA that are available. So coming to nusinersen, which in our center we are giving to some children. Nusinersen we know is very valid and very efficacious. It treats them very well. It's an intrathecal, into the spine injection. But it is expensive. It is 5 crores for the first year and roughly 2 crores thereafter. And yeah, 88,600 euros per vial. And each injection is about 87 or 88 lakhs in Indian rupees. So this is to talk about the new medicine which we are about to start giving for our children with SMA, the oral risdiplam. This is an oral medicine instead of the injection. And these are the trials that are freely available on the internet that showed how it worked in type 1 SMAs who are young, how it worked in older children, and much more older children, the sunfish, the jewelfish, and the rainbow fish trials. So Firefish is still ongoing for early onset SMA patients. So this raises the possibility of newborn screening. Newborn screening in the sense that, for example, we know for a fact that when SMA children are affected, the interventions that we have will stop the disease at the level where the affectation we've detected is. So we are able to detect the disease only when they manifest the symptoms. So to get it early on before they manifest weakness is very difficult. But sometimes it is possible in children, say, for example, if one sibling, one brother or sister has had SMA, then the parents are always worried that the second child may have it. So then early on when the baby is born, it is tested. But the other alternative is doing something called as newborn screening. So this might become one day a reality when we have already a reality in certain places like Taiwan, New York, and southern Belgium, where if you at birth pick up problems, then but we can do that morally and ethically only when we have a solution to give patients and families. But in the US, in certain places as well, newborn screening has been instituted. So gene therapy is another possibility. Zolgensma, part of gene therapy for SMA, the most expensive drug in the world, 2 million US dollars. These are all the trials that are and the various ways it is working. For this is from the SMA, the International SMA Parent Support Group of Spinraza that's been approved and used for all types, and Zolgensma approved, but mostly for patients too. And you're talking about risdiplam, which is risdiplam is now pre-approval, so it's awaiting approval by the 24th of August. And then you have other drugs in the pipeline like branaplam, olezoxime, and resdimtin and SR4. So then coming to other neuromuscular disorders, LGMDs, your neuropathies, congenital muscular dystrophies, congenital and acquired myasthenias, all of these diseases, what they have in common, these are much more rarer than SMAs and DMDs, but what they do have in common is that many of them, like the SMAs and the DMDs, have cardiac involvement, have diaphragmatic weakness, which means they have respiratory weakness. They also need multiple specialists taking care of them. And they are also they're all single gene diseases, and most of them may at some point in the near future will have cures. So this is a cartoon of all the various proteins. If you remember in the first slide, we showed the cell membrane and the nucleus, and you have the dystrophin protein. And the dystrophin, this is a dystrophin protein here, and you have all the other proteins. Here you have the sarcoglycan complex. Each of these, so for example, if this is missing, you have delta sarcoglycanopathy. If this is missing, you have alpha sarcoglycanopathy. If fucotin is missing, you can get either an LGMD or you can get a congenital muscular dystrophy if it was very early on in birth. So if you have collagen missing, you have Ulrich muscular dystrophy or Bethlehem myopathy. Caveolin can also cause LGMD1C. Dysferlin can cause this particular LGMD. TRIM can cause LGMD. Telotherrin, titinopathies can happen. Myosin can happen in myosinopathies. So we have different diseases. So challenges that are unique that we have a lack of regulation. There's a lot of things like stem cells going on. We have high degree of consanguinity, and there is a lot of things with economic disadvantage. Even today, only those of you who are educated and who have access to, have internet and hi-fi and smartphones and laptops and computers can be part of this. So these are the challenges that are unique to us. But the other challenge, the other pro side is that we are a young and developing economy. Maybe most of us can come together, and Corona as well can help us collaborate with each other a lot more. So now we know that for the SOC, say for example, we do know that cardiac care has to be much more rigorous, and that most of our children, we tell them come to Baptist, come to Bangalore and get it done. But maybe we are going to have to do all of these things remotely. So unity and collaboration may be the answer to all of this. So families and children, medical professionals, scientific community, parents, government and NGOs have to come together. This is the only solution that I can think of. That's it, Mr. Prasanna.
Okay. Can you answer? Yeah.
I can't hear you.
Hello. Thank you very much,
Hello.
madam. Let me know if there are any questions from the audience. There was one question. What is it? What about newborn screening for MD from Anuba?
So the ethics of newborn screening is complicated. It's only when you can give a treatment. So for example, SMA, we can do newborn screening, we can think about it because the free drug is available now. But the free drug is available only for a short period of time. I've been approached with saying that Risdiplam will be available for children who are pre-symptomatic if we pick them up early. But that also is only for a short period of time. So who's going to pay for the newborn screening? So you would have to, if you say DMD occurrence is 1 in 6,000, so you would have to screen 6,000 children to get one DMD. So who's going to pay for that 6,000? And that's one question. Second one is, once you get that child, the child 1 in 6,000 child early on as a newborn who has DMD, then what? What are you going to do next? We had this dilemma when I trained in the UK. There was a pilot program by the UK government. They used it only. UK, as you know, has got 4 parts: Wales, Britain, Ireland, and Scotland. So in Wales, they had a pilot program where they had newborn screening to pick up DMD. Very simple program. You just have to do CPK because CPK is so high in babies in the newborn period. So they picked up all these children with DMD. Unfortunately, we had crying and wailing parents coming to us, and we had nothing to offer them. So then we had to suspend the program because we had nothing to offer them. So we can ethically institute a newborn screening program only when we say, okay, fine, like etipleucin or cerepleucin or whatever, exon 51, sarepta 51, 45, 40, 53, for everything, for most of them, we have a cure and it is possible to give it to patients. If that happens, then definitely newborn screening should be done. If it doesn't happen, chicken or egg, which one should we be concentrating on? I don't know. Does anybody else have any thoughts on it?
Yes. Madam, can you see the chat box there? There are questions being posted.
Okay. Can you do NMD diagnosis by amniocentesis? Yes. You can. Somebody has asked, can you do NMD diagnosis by amniocentesis? Yes, you can do amniocentesis diagnosis, but you can do it only if you have an existing genetic diagnosis. So if you have a pre-existing child, the previous child who had a diagnosis, then you can look for that mutation, because in the same family you can't have multiple genetic problems. You would have the same problem again and again. Then you can do it. There's another question for MPS type 2 patient. Please give some tips to control hyperactivity and toe walking. Okay, that's a difficult question to answer. It depends on what is causing the MPS's type 2 toe walking. It could be something to do with the spine. It could be contraction of the spine or something to do with the brain. You would have to assess the child. And tips to control hyperactivity, we'd have to assess the child and give the child medication for hyperactivity or give them interventions for hyperactivity. Both behavioral interventions as well as medical interventions are possible. Another question, Mrs. Madhuri Chatterjee. Can we start heart medication like eplerenone and losartan even if the echocardiogram is normal? Yes, the answer is no. Yes, but you don't start it. It has to be started by a physician, because as we just showed, echo does not pick up all abnormalities. Cardiac MRI, Holter, and functional studies pick up abnormalities. We proved that to ourselves by doing. We started instituting. That's a very good question. We started instituting cardiac functional studies and extensive studies only from last year, from 2019, mid 2019, and we picked up a lot of abnormalities which we did not pick up in 2018. And this is taught as a lesson, and this is where the international guideline comes, saying that even if the heart is structurally normal, there is invisible cardiac damage, and so we need to do it. Then, okay, ma'am, understandable. Okay, can we follow up checkups? Can we delay follow-up checkups due to COVID scare? You can delay to some extent, but you can't delay too much because the corona is going to last for at least 1 year. So you're going to have to come up with alternatives. We have to come up with telemedicine, find your own doctor, contact your specialist, and then, no, you can't delay too much. We've delayed by 3 months. It's already too late. Then what happens is then you end up with side effects because then all our rare disease children will start suffering. So hopefully that's the answer to that. Any clinical trial to be started in India for DMD? We are trying. How to address the weight gain issues associated with DMD? Okay, that's a very good question. Weight gain issues with DMD. We don't have any problems with weight gain with DMD. Most of our patients don't gain weight because we control it. So we don't give steroids in DMD just like that. We prepare our children. Before starting weight, we psychologically prepare the family as well as the children. So if you gain weight, it's usually the first 3 months. So we also select the group of children that we start steroids on. And in the first 3 months of starting steroids, if you don't gain weight, you're not likely to gain weight. So this is something that I don't completely agree with. I've worked both in the UK and India. And in UK, I saw more weight gain than in India. And I'm attributing that to the fact that Indian parents do a lot of helicopter parenting. We don't we don't leave our we don't leave our children alone. We are very, very, very careful. And parents, those parents who are motivated are really motivated. So I don't agree with that. I think if you give them right instructions, parents really take care of it and they don't do it. What about cardiac respiratory checkup for LGMD if you don't have any such symptoms? So it's not about symptoms. You don't get symptoms. The whole point is by the time you get symptoms, it's too late. You've already had damage and you can't reverse those damage. Stem cell therapy for DMD, another question, doesn't work. I have colleagues who are doing research on stem cell. One day it may work, but it doesn't work. This is where I'm saying, don't believe me. Look at the ICMR website. That is the Government of India website, which is warning doctors strictly that's not to give stem cells. So definitely not for muscular dystrophy or neuropathies. Doesn't work. It may work one day, but if it is working, if it is part of a research study, it has to be free. So that's it. I think that's most of the questions, Mr. Prasanna.
Yeah. Okay. If I request the participants, if they have any questions, they can post it to our website or contact us. Then we'll get back to you with a relevant answer. Thank you very much, madam, for insightful presentation. And I'm sure it has helped a few of the patients and families, and also some doctors. I would like to thank you on behalf of ORDI team for your valuable time, and also all the participants who have taken effort to join this call. And I thank my ORDI team, backend team, Swami, Swapna, and Pavitra for organizing and managing the entire show.
Thank you very much, Mr. Prasanna, for organizing this. One last thing. There was one person whose question came in the end. He asked, is there anything about natural history? Yes, there is a lot of studies on natural history. So all the information. So Dr. Valeria Ricotti is somebody who has published a lot of data on natural history, natural studies of DMD. So there's a lot of data available. If you ask them to go and look at the websites, Treat-NMD has got those studies on natural history, saying what happens for steroid naive children. So that's the natural history. The 14 years, 18 years death and cardiac complications and all that. So that's for further information.
What is the name of the doctor you said? I think they're asking the full.
Valeria Ricotti. Ricotti.
Okay. Thanks, madam.
Okay.
I think we have finished well in time. Thank you very much. So I request all the participants to log off. Thank you. Thanks once again.